I'd like to introduce my colleague, Jane Larkindale. Dr. Larkindale has served as the Vice President for Research and Development at FARA since 2014, and she concurrently serves as the Executive Director of the Duchenne Regulatory Science Consortium at the Critical Path Institute in Arizona since 2015. In both these jobs, Dr. Larkindale is dedicated to accelerating drug development for these rare diseases. At FARA, she supports research, develops infrastructure, and helps researchers source the tools they need to accelerate drug development. Through the Duchenne Regulatory Science Consortium, she leads an international group dedicated to developing regulatory drug development tools for Duchenne's muscular dystrophy. By training, she's a molecular biologist and had completed her PhD at the Department of Plant Sciences at Oxford University in 2001. And she attended there on a Rhodes Scholarship. Her experience in drug development and neuromuscular diseases started at the Muscular Dystrophy Association, which is an international nonprofit organization that covers over 40 neuromuscular diseases. She worked there from 2007 to 2014, and her last position there was as Vice President for Research. So please join me in recognizing Jane Larkindale, who's going to spend an hour and teach everybody about gene therapy. Thank you.
Hi. It's great to be here. It's great to see such a group of very engaged people. I think you might have noticed in Katie's bio that she just read, the one thing that is not in there is I have never worked in gene therapy. I have worked alongside gene therapy. I've worked with people in the field for quite some time, but I've never actually done gene therapy in any form in terms of people. I did genetically modify some plants somewhere way back in the past. So it's great to be here. I hope that the next hour will be informative. I'm going to give you some basics about gene therapy and how we're hoping to apply it in Friedreich's ataxia. If at any point I'm talking too fast or you don't understand, feel free to gesture at me to slow down or go back or to explain something further. And I hope there'll be plenty of time for questions at the end. I think anybody who reads magazines, reads newspapers, watches TV has gathered that genetics is at a very exciting stage right now. Gene therapy seems to be in the news everywhere. When something we work on in the rare diseases field is in Time magazine, National Geographic and such like, it means things are really moving forward fast. And it's a really exciting time for gene therapy right now. We had the first approvals in the US of gene therapy products within the last year. There's a gene therapy for a rare form of blindness that gained FDA approval. There was a GlaxoSmithKline drug that got EU approval. There are things called CAR T cell therapies, which are genetic therapies that have been approved. So there's been a lot of movement in this field, really, in the last year or so. There have been 3 gene therapy products approved in the US at this time. Kymriah for a form of pediatric leukemia, Yescarta for a form of lymphoma, and Luxturna for biallelic RPE65 mutation-associated retinal dystrophy. That's a long name. There are 2 that have been approved in Europe. They are different. The 2 that are approved in Europe are not approved in the US and vice versa. Those things will come together in the end. So there's been plenty of news even in Friedreich's ataxia. These are some headlines I pulled off the web about some of the companies that are developing gene therapy in Friedreich's. There's a lot of news out there. Which comes to the question I'm sure you all have and we all have, is, so why don't we have a gene therapy for Friedreich's yet? What we do is not in the clinic yet, and that's what I'll be talking about a lot today. It's not because nobody's working on it. In fact, we actually have a lot of activity in Friedreich's ataxia gene therapy. These are 5 companies that are working in the space. There's a smaller company, Bamboo, that was bought by Pfizer that's not represented aside from under the Pfizer logo. We have a lot of activity in gene therapy and Friedreich's ataxia. And we have even more activity in the academic realm as well as those companies. So it's certainly not for lack of trying that this isn't all the way through yet. So what am I going to talk about today? I'm going to start really with the basics. What's a gene? How do they work? And what is a gene therapy? This is probably a good place to start. Some of you know this already, but it's a good place to start. We'll talk about whether Friedreich's ataxia is a good candidate for gene therapy. I think you can probably guess by that last slide how many people are working on it. Yes, Friedreich's is a pretty good candidate for gene therapy. We'll talk about how gene therapies are developed, where we are as a field, and specifically where we are with gene therapies for Friedreich's ataxia. Then we'll talk a bit about the risks of gene therapy, as well as the potential benefits of gene therapy. Like any other drug program, just as Dave Jacoby was just saying with his HChat, of course there are risks, there are potential benefits, or we wouldn't be doing it, and it's all a balance of risk versus benefit for any drug development. And we'll finish up talking about the road ahead. So back to the basics. What's a gene? It goes back to high school. A gene is a functional unit of genetic material, or DNA. We draw them as these pretty squiggles all the time. Basically, a gene codes for a protein, and the protein is what does something in the cell. And in the case of Friedreich's, do I have a pointer here that I can reach with? Not really. Good. Let's go backwards. In the case of Friedreich's, most patients have this big honking elephant called a big GAA repeat in the middle of the gene. As Dave has already explained, that means we don't get enough frataxin protein, and that's what causes the disease. So the bottom line is, Friedreich's patients don't have enough frataxin, we need more protein. You can do that by putting more protein in. That's called protein therapy, we are looking at that. We also can put a new gene in or fix the gene, and that's what I'll be talking about here. Where do we need frataxin? Again, I think this is a question most of you know. We need it everywhere. We need it in our patients, we need it pretty much in every cell of the body, but there are some cells that need frataxin more than others. Different types of cells produce different amounts of frataxin, and particularly in certain tissues, we need frataxin more than others. So why can't we just put the gene back? That's kind of what we want to do. That's what gene therapy is about. Let's fix that gene. So you start off with the gene, the frataxin gene. If you're making gene therapy, you can't just inject that gene, put it in the body, and expect it to go to every cell of the body, produce its protein, and all is hunky-dory. We do it by, we try and get that gene in using something called AAV. AAV stands for adeno-associated virus. It is a virus. It is not a dangerous virus. This virus does not make you sick. Many of us will have already been exposed to AAV viruses. We don't know about it because they don't actually do anything. But what they do is, like many other viruses, is they take little bits of DNA and they shove it into your cells. Normally, when that virus is going to make you sick, you don't want to shove bits of DNA into your cell. That's going to make you sick. In this case, that's exactly what we want. We want that frataxin to get into the cells. So we take our frataxin gene, we coat it up in this AAV capsid, you inject it into a patient, and the idea is then that virus goes and infects the cells, throws that frataxin gene into the cell, and the cell starts producing the protein. And that should have therapeutic benefit. So what is the gene therapy? The gene therapy is essentially the gene. That's the instruction manual as to how to make frataxin. And it's the delivery mechanism, that AAV virus, which is going to deliver that frataxin gene into the cells. And we'll be coming back to this concept a lot. You'll see an awful lot of pictures of that owner's manual and a little truck full of balloons, because that is your gene therapy, bringing that gene into the cells of your body. So I mentioned earlier, any therapy has advantages and disadvantages. There are good things and there are bad things. Gene therapies in particular, there are reasons why a gene therapy is a fantastic solution, and there are reasons why maybe it's not so good. So let's start with the advantages. In terms of a single gene disease like Friedreich's ataxia, gene therapy really is treating at the root cause. The root cause of Friedreich's is we don't have enough frataxin. The frataxin gene is mutated. You replace the gene, so anything that frataxin does should be fixed by replacing that frataxin gene, or anything that happens after the time you fix it. So that's a huge advantage. It could be permanent. In theory, a gene therapy, you put it in, you do it once, you don't have to treat again. It's probably, full disclosure, it's probably not going to be permanent in the first instance, but it's certainly going to last a reasonably long time. It's not a treatment you're going to take every day. And you probably won't require repeated treatments. So those are the advantages. Gene therapy sounds great. What are other disadvantages? That we still have risks of immune reactions. Those capsids are viruses. Your body may react to the virus. AAV is less immunogenic than many viruses. There's been a lot of research into these problems. Since gene therapy has been around, this has probably been the area there's been the most research into. Another disadvantage, You put a gene into your body, you put that gene into your cells, you can't go back. It is irreversible. If you take a small molecule drug and it doesn't work for you, it starts causing problems, you stop taking it and hopefully after a little while, you're back to normal. This is irreversible, you can't turn it off. And that's why we're very cautious, we move very slowly with gene therapies. That you can't turn it off is a good thing if it continues to work the way it's supposed to and it's safe. So that's a catch-22, you can't have it both ways. Another disadvantage is gene therapies are very expensive and difficult to manufacture and develop. So that's another reason why it's taking a long time. And right now, re-administration is not possible. I say this hesitantly because there's beginning to be some research in Pompe disease where it may be possible to give a second dose of a gene therapy, but we're not there yet. That's something for the future. So with all that in mind, there are good things about gene therapy, there are bad things about gene therapy. There are also many different types of gene therapy. On the left-hand side of the screen, we have what's called ex vivo gene therapy. This is gene therapy that's done outside the body. You take cells, you fix those cells, you put them back in the body, and the cells do what they want to do. This is less permanent. It's much more like a regular therapy. That's not what I'm going to be talking about today, but Stephanie Shepke, who's talking after lunch, she's going to be talking about ex vivo gene therapies. What I'm going to be talking about is what's called in vivo gene therapy, which is where you fix the gene inside, or you replace the gene inside your own cells. Lux Turner, the third of those FDA-approved gene therapies, is an in vivo gene therapy. It's the first one that's been approved. And I think this is probably the further ahead form of gene therapy for Friedreich's. So that's what I'm going to focus on. If you're scared by what I said about the advantages and disadvantages of gene therapies, these are a small subset of the gene therapies that are going on now, that are in the clinic now, that are going into patients now. I inherited the slide, I started editing it. You can no longer fit all the gene therapy trials onto one slide. There's a lot of work that's been done, a lot of experimental gene therapies going into patients now. You'll see a lot of them in phase 1, that's very early safety testing. But we can learn a lot from all these other diseases. Some of the issues like the immune responses, if it's to the virus, that's going to be the same regardless of what gene you're putting in. So we're learning from all these other trials that are going on, have gone on. Some of them are quite a long way through. We have one approved therapy. There's a lot of work out there. We're not first. I think that's a good thing for our field. We can learn from all these other experiments that have been done in other diseases. Is Friedreich's a good candidate for gene therapy? We weren't the first disease to be tested. Are we a good candidate? My overall conclusion is yes. We're a monogenic disease. We know what's wrong in Friedreich's. All we need is more frataxin. So that makes us a good candidate. Perhaps even more importantly, everybody in this room has some frataxin. That means that our bodies have all seen frataxin before. It's not a foreign protein, so our bodies are unlikely to develop an immune reaction to the frataxin itself, which is huge in the gene therapy world. If you introduce a new protein, your body's never seen it before, your body may develop an immune reaction to that protein, which means it can't be expressed and it won't work. So from that perspective, because we all have some frataxin, we're a great candidate for gene therapy. There are discrete tissues. We know where frataxin is needed the most. We need it in the spinal cord, we need it in the brain, and we need it in the heart. We need it everywhere else as well, but if we could correct those tissues alone, we would have a huge, profound effect on the disease. So we know where we need to get it, at least on a macro scale. And the frataxin gene is actually quite a small gene, and small enough to fit into this AAV vector. You think this is a minor thing? I also work in Duchenne muscular dystrophy. The gene that's mutated there is the biggest gene in the human body. They can't put the whole thing in. They have to cut it into pieces, stick it back together, and put it in. And that's going to make things a lot more complicated. Frataxin is small. We can put the whole thing in its native form into that virus capsid and use it as a therapy. So, yes, we're a good candidate for gene therapy. We still have concerns. Yes, there could be an immune reaction to the virus. This is being handled in other diseases. We need to be aware of it. We need to get frataxin into the mitochondria. It's not an excreted protein. We can't just have one cell produce a whole lot of it and get it out there and excrete it to other places. So we need to have pretty good coverage with our gene therapy. And as I said, frataxin is needed in every cell to some degree, although we certainly know that some tissues need it more than others. On the balance, I say, Friedreich's is a good candidate for gene therapy. So, I think we've got to the point where we've decided that perhaps this is a good way to go for Friedreich's. How are we going to develop a gene therapy for Friedreich's? It's a long process. Up there on the left, identify the gene of interest. We can tick that one off the list. We know what's wrong with Friedreich's. We know what we want to do is put frataxin in. So that's good. We need to develop an expression system. That's the owner's manual. We need to develop what those instructions are to make frataxin that we want to put into the virus, to put it into the patient. It's pretty obvious. We need a frataxin gene, but we also need things to turn it on, things to turn it off, and a few other pieces as well. So we need to develop that expression system. We need to identify the delivery vehicle. I mentioned AAV. I'll talk a lot more about that virus that will deliver the frataxin as we go through these slides. Once you have those things together, you need to prove that it works in cell models first, then probably animal models. You need to make sure it goes to the tissues you want it to go to and does what you want it to do, preferably doesn't do things you don't want it to do. And at the same time, you develop a manufacturing process. I already mentioned that manufacturing gene therapy products is not simple. We can't just go out to the factory and say, hey, make me frataxin gene therapy, we'll have it tomorrow. So that's actually a fairly complicated process. Once you've done that, you've gone into an animal model, you've gone to your cells, you can correct them and it's all looking good. You then have to scale up your manufacturing, make more of it, make it more pure, make it more precisely, and go into what are called preclinical and IND-enabling studies. IND stands for Investigational New Drug. That's what you do for any new therapy. There's a whole series of studies you have to do. And that is kind of the gauge point. Once you've got all those IND studies, you take it in the US to the FDA and say, here's my IND package. Here's all the data I have supporting why I think this is going to be safe. Here's all the data why I think it's going to help patients. Here are all my plans for my clinical development. And with any luck, you can get into a phase 1 trial, safety trial. And Dave Jacoby just talked about that with respect to the HDAC. They're hoping to get there by the end of the year. Gene therapy is a little behind that. It's probably going to be next year before we're beginning to see these come into the clinic. But we're getting there. In gene therapy, you don't tend to do as many trials as you do in small molecules. They tend to be smaller, they tend to be slower, they tend to be more careful and considerate. And that comes back to the fact that you can't reverse it. So you usually start with one patient, see what happens before you go to the next patient. So these trials can be fairly slow. You go through the trials. At the end of that, you get your regulatory review. Again, the FDA goes through all your data, all your safety data, all your plans, everything you've done. And if they really think there's a chance this has more benefit than risk, there's always risk, there's always benefit, then you finally get to go to patients. So that's the process for developing a gene therapy. Where do we start? That's a pretty picture of frataxin. It's probably not that multicolored. It's a pretty molecule. That's the gene responsible for Friedreich's. We know it functions in the mitochondria, and we know where we need it. That's a good first step. That ticks off that first box on the flow chart we just saw. We know the gene, we know where we want it to go in terms of tissues and within the cell. So now we need to develop that delivery system and the vector cassette. The instructions and the delivery system. Both of these are flexible. I mentioned earlier there are lots of groups working on them. They each have their own expression cassette. They're all working with different vectors. So that's why we have so many people in the space. Everyone's got their own version of this. So let's start with the expression cassette. That squiggly line up there, that's frataxin, along with its introns and exons. The blue bits are the bits that actually code for protein. So we take those bits, put them together. We don't need to care about stuff in between. That doesn't need to be inserted. We need a promoter. The promoter tells you, turn on frataxin. How much does it get turned on? Where does it get turned on? And you have lots of options. That promoter sequence typically comes from something in nature. You can use what's called a ubiquitous promoter that's turned on all the time. You could use the frataxin gene's own promoter. There are lots of options there. Different groups are using different types of promoter there. It tells you turn it on and how much to produce and where to produce it. You also need at the other end the stop sign. It says stop transcribing protein here, or you end up with frataxin with blah, 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 blah attached at the end. It probably won't work well. So you have to have a start, you've got to have a stop, and you've got to have frataxin in between. That's what's called an expression cassette. That's the easy part. You then have to choose a vector. A vector is this virus that we're talking about. And we use these viral vectors because it's the best thing we know to get into cells. In theory, you'd think some smart scientists out there would come up with a good way of delivering new genes to cells. They can, but nature's actually probably smarter than scientists, and scientists have decided to use nature because these viruses work much better than anything that's been built synthetically. Different types of viruses work differently. Some viruses actually integrate into your genome. That means that they come into your DNA, they stick themselves in, and they start working. Generally in gene therapy, we don't think that's a good idea because we can't control where it would go into your DNA, and it might cause more problems than it's worth. AAV, the one that's largely being used now, does not integrate. It sits around in your nucleus, it doesn't do anything to your existing DNA, and that's generally considered to be a good thing. Different viruses get into different cells. If you're trying to develop a Friedreich's gene therapy, you want to get into the central nervous system, you want to get into the peripheral nervous system, you want to get into the heart. If I was developing a gene therapy for Duchenne muscular dystrophy, I'd want to get into the muscles much more than into the central nervous system. So depending on your needs, you choose a different virus. But there are a lot of viruses out there, so we'll talk a bit more about that. They're viruses, they're living things, they're not without risk. Early on in gene therapy, we're talking back in the 80s, they were using a different virus. It was called adenovirus. There actually were a couple of deaths with very early gene therapy. We've learned a lot since then. I think everyone believes the AAV vectors are a lot safer than the ones that we used in the early days. These AAV vectors seem to be non-pathogenic. The immune system reacts to them much less. They've now been in a lot of patients. I showed you that list of clinical trials that are ongoing. There aren't many approved gene therapies, but we've put a lot of gene therapy vector into patients. They seem a lot safer. There have been clinical trials over 10 years now, and they do seem to be working pretty well. This is a family of AAV vectors. Different ones, as I say, go to different places. There are a number that go to muscle, there are a number that go to heart, there are some that all go to the liver. That's not very useful if you've got Friedreich's. I don't want a whole lot of frataxin in my liver, I want it in the tissues I care about. AAV9 is probably the one that goes to the central nervous system the best. So this is just an example of different gene therapies that are being used by different companies that go to different places for different diseases. If I'm trying to treat hemophilia and blood disease, I'm going to want a different vector than I am for Friedreich's. If I'm looking at Parkinson's, I might need a vector that's more similar to a Friedreich's because I want it in the brain. So there are lots of different things you can do to adjust your AAV for your disease in question. I like this the slide. So we started off with 9 AAVs. We're never satisfied with what nature makes. We like to shuffle it up, make it better. And there have been a lot of groups in the last 10 years doing exactly this, trying to take these AAV vectors, this nice little old-fashioned bicycle that we had to deliver genes to start with, shuffling it up, trying to make vectors that go better to the tissues we're interested in, ones that evade the immune system better. You shuffle them up, you direct them, you choose the best, you shuffle them up, you choose the best, you shuffle them up. Basically, you make these evolve into the vector you want for your disease in question. I would say that bicycles evolved about as far as my grandfather's car. It's not ideal yet. We're getting a lot better. We haven't got to the latest Ferrari, but we're doing a lot better than we were before. So the delivery vehicles are getting better. We've got some work to do. Jen and I visited a gene therapy lab yesterday where they're still working on making better viruses. As time gets on, we're getting better and better at this. How do we choose the one that we think is best for Friedreich's? What do we do? Well, on the left there, you can see AAV9. The bright green stuff is how much protein is expressed. That AAV9 in this example is not really expressing a whole lot of protein. So they shuffled it up. They came up with this AAV PHPB. You can see there's quite a bit of green. That's doing a lot better. But scientists are never happy. They shuffled it up a bit more. They got to AAV PHPEB, and you can see how bright that is. There's a lot of protein being expressed for that. So we're choosing our vector partially on how much protein is being expressed, how widely distributed is it in the tissues we care about. We also choose our virus very much on where it's expressed. In Friedrich's, we need it in the brain, we need it in the spinal cord, we need it in the heart, and we need it everywhere else, but those are the target tissues we're really looking for. And again, different groups have approached this differently. How do you deliver it will affect which tissues you get to. Some are very much focused on certain tissues, some want to get it everywhere. And again, that's the differences between different gene therapies. But that's how you choose which vector you want to use. Okay, we're moving on. We've got a vector, we've got an expression cassette, we put it together. Here's our gene therapy. What are we going to do next? We're going to push it into cell models. We're going to push it into animal models and see what happens. This is from a paper that came out of Helene Puccio's lab in 2014, where they used a mouse model of Friedrich's called the MCK mouse. This mouse, when you delete frataxin in the heart, this is a very severe model, there's no frataxin at all in the heart muscle of these mice. The mice die very quickly, that's the red line. The blue line along the top, that's a wild-type mouse who obviously lives a long and happy life running around his cage. And what's really nice here is the black line, which is the treated MCK mouse, looks like a wild-type mouse. They put the vector in, the gene expressed in that mouse, and the mouse looks really good. Furthermore, when they went downstream, these are pictures of the mouse's heart. You can see the wild type is all blue. That's a good thing. Those are the enzymes that are produced in a wild type mouse that are downstream of frataxin. And you can see in the second picture there's none of that. But when treated with AAV, the heart is staying like normal. Those enzymes that are downstream of frataxin look normal, behave normally. This mouse did really well with gene therapy treatment. Now, I quoted an old friend of mine who liked to say, it's a great time to be a mouse with a neuromuscular disease. We're really good at fixing mice. What we'd really like to do is fix people. And we're getting closer to that. Unfortunately, it's not as simple, we'll fix the mouse, now it's time to go to a human patient. But this is a really important step along the way. I'm not going to go through this slide in detail. I mentioned earlier, manufacturing these things is hard. There are a lot of steps, particularly as you start going towards the clinic and starting to do those IND studies, and even more so when you start to go on patients. This is a highly regulated process because you have to make sure this is clean. You have to make sure you know exactly what's in that final gene therapy that's going to be put into people. It's got to be pure, and it's got to be the same every time. So if I inject you over here, it does great. I can say, well, if I inject you over here, it's going to have the same effect because I'm using the same thing. It's a very complicated process. It's very highly regulated, and it takes some time. Okay, we can make it. We have it, we can make it, we can make enough of it. Let's start heading towards the clinic. Well, IND-enabling studies, that's the studies you need to do to move towards this investigational new drug application. They're highly prescribed. There are a number of things you need to do. You need to prove that you're manufacturing the same thing every time. The same amount of virus, the same amount of frataxin protein will be produced. It's clean, there's nothing else in that prep. You've got to demonstrate safety in a number of animal models. You've got to do a whole lot of studies figuring out where that virus is going, what's going to happen to it, how long is the virus going to be there, how long is the gene going to be there. There are a whole lot of prescriptive steps you have to do before you can go and meet with FDA and say, hey, let's go into the clinic with this. I've seen a number of these IND dossiers. You're talking about a book that thick of information before it goes to the authorities, which they review in great detail. But if they like what they see and they think there's a better chance of benefit than risk, then we can move forward to the clinic. And that will be an exciting time when we get there with the gene therapy. Companies in the space are probably likely to get towards their IND application by the end of this year. So we're not talking 20 years in the future anymore. We're talking soon. We'll get to that stage soon. The FDA says yes, we start clinical trials. They will start off very small. That's standard for gene therapies because of that fact you can't turn them off. You start small, you start slow, you will start building the case. And as you get more information, you really start seeing, say, nobody's having any problems, you can increase the number of patients, you can look at them over longer, and we hope we'll start seeing benefit fairly quickly. There are going to be issues with trials. With gene therapies, if you're in one trial, you may not be able to be in another gene therapy trial. These viruses are closely related. Once you've been exposed to a virus once, your immune system will react to it. You may not be able to go into a second gene therapy trial. We're hoping that we can manage the response of the immune system, but We'll start small, we'll start slow. Once we get in the clinic, we'll know a lot more. It's been done in other diseases. It can be done. It has so far seemed safe in other diseases. If our initial small trials are good, they're likely to be followed by larger ones and longer follow-up. They'll still be small. We're not going to be putting these in sort of trials of hundreds of patients. The ones that have come close to the market are small phase 3 trials, but we will continue to have trials before the drug can be approved. So that's gene therapy, gene replacement therapy. I added this section at the end of the talk because there's been a lot of buzz in the news about gene editing. You hear it a lot in the rare disease community. Hey, why would we replace the gene if we could go in and fix all of our genes? Let's just cut that repeat out and we'll all be good. Gene editing is probably one of the most exciting technologies that's come into research in the last several years. It's being talked about even more than gene therapy generally. It's everywhere. How is this different from gene replacement? Well, the name really says it all. In gene replacement, you take a new gene, you shove it into the cell, the gene expresses, and it's separate from your DNA. In gene replacement, instead, you're putting something in that will go in and it will edit your existing gene. It will go in, it will cut those repeats out, it will fix your point mutation, and that cell will be normal thereafter. How does it work? You have a number of components. You have what's called a guide molecule. This tells the system what needs fixing. Where do I need to go in and cut the DNA? Start here at the beginning of the repeat, stop there at the end of the repeat, cut it out. You have a healthy DNA copy to replace it with because you don't want holes in your DNA. That generally isn't good for people to have holes in their DNA. And you have a special DNA cutting enzyme that cuts very specifically. So you're going in, you're really cutting a mutated piece of DNA out and replacing it with a healthy piece. Sounds fantastic. It's a long way off. There's a lot more we need to know. This field is moving incredibly fast. This is a complicated slide. If you look at those little orange boxes at the top, the first way of doing gene editing were these things called zinc finger nucleases. Each experiment took months. We're now using the little green one at the bottom, CRISPR-Cas9. Experiments can be done in days. This is a lot faster, it's a lot more efficient. This field is moving very quickly. Back in 1996, when zinc finger nucleases were first developed, they took till 2002 before they put anything into a live animal. CRISPR came on the field at about halfway through 2012. By 2015, British scientists used talons to cure a child's leukemia. It's moving fast. It's not all the way ready for prime time. That was ex vivo, by the way. That was not done inside a patient. But there's a lot of movement in this field, and it's accelerating all the time. In terms of Friedrichs, at the moment we're at very early stages with this technology. FARA has funded one study with a company called CRISPR that's really looking into this with the University of Alabama at Birmingham. It's exciting, it's really cool. Where we are right now is you still need to deliver this gene editing paraphernalia using an AAV virus, just like with gene replacement. It's more complicated, you'd have to hit every cell. Right now, I would say gene replacement is much closer to the clinic, much closer to reality, but we don't want to leave gene replacement behind. So we're still putting money into it, we're still working on it, but it's a ways off in terms of the technology and getting it where we need to go with high enough efficiency to get a treatment. That's one that I would say, 5 years ago I met Janet at a meeting and I said, gene therapy is way off. I was wrong. I'm not going to say that about CRISPR, but there's a lot more we need to learn. It's a ways off yet, but we're learning. It'll go faster than we think. So where are we? We've got people working throughout this flowchart. We've got people like CRISPR right at the beginning who are really sort of doing very basic discovery work. And we have people at the other end, like the University of Florida and Agilus, who may well file for IND this year and get into trials next year. It's an exciting time in this field. And we have people all the way through. I talked about the differences in gene expression, in this gene expression piece, and differences in the vector. Each of these groups is doing it slightly differently. You might say, why aren't we putting all of our money and all of our effort into one of these groups and pushing it forward as fast as possible? The answer there is, we don't know which one of these is best. We want to have as many shots on goal as possible. They'll shake out, we'll figure out which one's best as they go through the process. But they're all slightly different, and any one of these may be the best in the long term. So that's really the information I wanted to talk about. I've got a number of questions for thought and discussion that I know people have. People talk to me and then we'll move into discussion as a whole. What are the questions we get a lot? How long will a gene therapy last? We've talked about the fact that we may not be able to re-administer. Is this something that's going to last my entire life? What we know is in hemophilia, some gene therapies have shown expression for over 10 years. That's mostly in dogs. A few hemophilia patients and kids with blindness was injected into the eye. We expect the transgene will continue to be expressed as long as our cells turn over. Fortunately, the cells in our nervous system don't turn over as fast as some of the other cells in our body. The cells in our heart don't turn over as fast. So this could be the lifetime of the person, but we don't know yet. So that's still an open question. What if it doesn't work? Can I be re-administered with a different one? We'll talk about the fact there are lots of different ones. Right now, there's been a few examples of the eye where one eye was injected and then another eye was injected. There's been one experiment in Pompeii to see if it's possible outside of the eye. The answer is I don't know the answer to that question at this point. If I had to give you my hunch, is it's going to be a problem, but we'll solve it. The question is when. Another question out there, which is still an open question that we're talking about, is when's the best time to treat our patients? Ideally, I think we'd like to treat as early as possible. Can the effects of low frataxin be halted or reversed? Well, the cardiomyopathy in the mice, those mice I talked about, it suggested we could stop it, perhaps even reverse it. UCLA mice that Sue talked about. Again, it seems like it may be possible. There also may be developmental issues, things that happen as a patient is growing up that we may not be able to reverse. We don't know. Our hunch is we probably want to intervene early, but it may still be effective when we intervene late. We don't know. What are the remaining challenges? We're still working on those vectors. We've got good vectors. We've got my grandfather's car of vectors. We're still engineering better ones. I think that we're beginning to get vectors that have a good chance of being effective in the tissues we care about. We still want better ones, but you always want backups. Will the immune system react? I don't think the immune system is going to react to frataxin in the case of Friedreich's, but we may have reactions to the vectors. People have talked about temporary immunosuppression while you put the virus in. That's done in a lot of trials. New vectors are a lot less immunogenic than the original ones because people haven't seen it, so maybe that won't be necessary. These are questions that are still being discussed. The last one, I hate to even bring this one up, is can we afford it? Gene therapy medicines are hard. The ones that have got on the market are crazy expensive. Can we afford to pay for them? I don't think it's a personal question. This is really a government, greater world question. These are hard to make, they're difficult to make, they're expensive to make, but it's more like a vaccine. It's something you do once, it's not something you do forever. So I think there's a problem we can overcome, but it's not a problem we can ignore. Finally, what are we doing in this space as FARA? We're actually doing a lot. I don't develop gene therapies, Jen doesn't develop gene therapies, we don't do it ourselves, but we're doing a lot to support the development of gene therapy. In terms of the regulatory space, I think it was Dave Jacoby from BioMarin said when we first interacted with FDA, they knew nothing about Friedreich's. We've educated in the last 10 years. It's a different division of FDA that reviews gene therapies than reviews small molecules. The biologics division doesn't know as much about Friedreich's as perhaps the drug development division does. Fortunately, one of the very senior people there was actually a treating physician who treated Friedreich's patients. He was in our patient-focused drug development meeting. He knows Friedreich's, but we had a meeting last year with CBER as a whole to tell them really about the disease, about patient experience with the disease, and getting them ready to see these first gene therapies. We also, as I think many of you know, had a patient-focused drug development meeting in June last year. I know some of you were there. Again, this is all about educating the regulators about what our disease is, what you as a patient community want to see in a treatment. We're still doing plenty of research grants in the gene therapy space. We've funded some of the basic proof of principle work early on. We're still looking at work into new vectors. I talked about our grant into CRISPR to start looking into gene editing. We will continue to support this area as long as it makes sense scientifically. Developing gene therapies, we talked about the fact that gene therapy trials are going to start small. Dave talked about needing biomarkers to make our trials shorter. Dr. Perlman talked about using biomarkers to make our trials shorter. It's just as important in gene therapy. FARA has put a lot of time and effort into developing biomarkers, and we're continuing to do that, trying to develop these markers that will tell us sooner whether the treatment looks like it might work or not. Conferences, education and awareness. I think that's what we're doing right now. We've had a number of discussions about gene therapy with the patient community. We attend the American Society of Cell and Gene Therapy annually, both members of our board and FARA scientists. We had a number of gene therapy talks at the International Ataxia Research Conference last year. We're really trying to bring gene therapists into Friedrichs and Friedrich scientists into the greater world of gene therapy to learn from other people. Patient engagement. This is where everybody in this audience comes in. A number of our patients go out and visit the companies, remind them that our patients are real people who want this. Ask the questions directly from the companies, make the companies aware of who we are and why they're doing what they're doing. I don't know how many companies I've talked to who said this is very effective, actually meeting the community and seeing who it is they're working for. And I think just about every one of our gene therapy companies has had a visit from a group of patients, and that's incredibly useful. So thank you if you've been involved with that. And we're also involved with advocacy. Ron Bartek leads this. He's on the board of directors for the Alliance of Regenerative Medicine. He went with the Jewett family to NIH to talk about gene editing and CRISPR. There was the NIH director's blog that featured the Jewett family. This is all great. It draws attention to Friedrichs, it draws attention to gene therapy and how the two can come together and move forwards. So we're busy in the space even though we're not actually developing the vectors ourselves. There's a lot of work going on. It's a really exciting time in gene therapy. We've got a lot more to learn. And with that, I'm going to stop talking and see if anybody has any questions or anything I didn't answer with that talk. Thank you.
If you try gene therapy and you don't get significant results, can you do gene editing?
Right now, the way the technologies work is all the components are introduced to the body using AAV viruses for both. So right now, no, you can't. It's possible if we develop significantly different viruses, it might be possible in the future, but right now the answer is no.
I have another question, if you don't mind.
Sure.
So let's say you try a gene therapy and you don't get significant results. Why can't you do a re-administration of that same type?
So the issue there is the virus that you use to bring the gene in. So it's a virus. It's just like the flu virus or any other virus. Your body is going to develop an immunological reaction to that virus. So if it sees it again, you're going to have a massive immune reaction to it. And it will either kill the virus or make you incredibly sick. Now, if you could have a virus that was significantly different from the first one, your body recognized it as being different, then it might be possible. If you were highly immunosuppressed when you had that first treatment, it might be possible. These are all things that are being looked at, but right now, a second administration would mean that your body would fight it off and it could make you very sick or just not be effective.
Oh, okay, thank you.
There's a question here.
Yeah, who do you think is furthest along with gene therapy?
So the question was, who do we think is furthest along? And that's very hard to say because a lot of this research is cyclical. You move forward, you discover a problem, you go back, you solve that problem, you move forwards. Right now, I think Agilis and the University of Florida are probably the furthest forwards, but Voyager and Pfizer and people are not far behind, and it's entirely possible that would flip-flop. So there's a number of these that could be in the clinic in the next few years.
Do they talk to each other?
We bring them together and make them talk to each other. There's certain things they won't talk about. There are certain proprietary information they won't share, but yes, there is definitely exchange of ideas. And in terms of things like biomarkers and how to do trials, a number of the gene therapy companies are actually working together with us to fund studies to make sure those trials are effective. So, and things that they consider pre-competitive, they absolutely work together. Kyle?
So I learned about the immunoresponse, and I had no idea before. And one of the things, and maybe you could back this up, is that like there's viruses, flu viruses that we're exposed to all the time, right? And so if they're using a virus that we may have been exposed to previously without knowing it, then the therapy might not work on us. So there's like a pre-screening, like, I don't know. So, I mean, that's just one of the many complications, right, that we have to kind of look out for.
Yes, so Kyle's bringing up a good point that I actually didn't remember to mention during the talk, but AAV viruses are everywhere. Probably around about 30% of people in this room has already been exposed to AAV viruses. Particularly those of us who are a little bit older have very likely been exposed to AAVs before. So depending on which virus we use, you may not be eligible for this kind of gene therapy. They can screen for it. They're not going to put it into you if you're going to have an immune reaction. That's not going to be a problem. You can pre-screen to see if you've been exposed previously. But it does mean some people may not be eligible for AAV gene therapy. Having said that, I talked a little bit about the viral capsid shuffling. Some of those shuffles make viruses very different to natural ones, and it may be that people can be treated with those viral capsids, but they couldn't be with a straight AAV9 that you might have been exposed to already. And this is an area that's still under investigation. But very likely, at least in the first trials, they'll pre-screen, and if you've been exposed, you wouldn't be eligible for the trials. Again, in the longer term, that's something I think may be solvable. In the short term, it's definitely going to be a concern. Okay, I think it's a question up front. The guy behind you,
I was wondering, there seems to be good data on the AAV gene therapy for cardiac benefit in animal models. I was wondering what the status is for like the nervous system side of things.
Sure. So the study I showed was the MCK mouse, which has protection deficient only in the heart and the muscles, so you couldn't test a gene therapy on the neurological system of that mouse. Since that study, Helene Puccio's lab has developed a neuronal knockout mouse and seen probably not quite as good results, but good results in that mouse as well. So there is good data in the central nervous system as well.
Jane, the difference in the clinical trials between what we think of as a traditional drug trial and gene therapy drug trials. In gene therapy, it's either going to work or not. And there may be some people that it doesn't work in that's in the trial, but it seemed that the progression through the 3 phases would be different.
Yeah.
And because it's more of a 0-1 kind of a situation than what percentage and was it significant, blah, blah, blah. Can you talk just for a moment about that difference?
Sure.
Once we hit phase 1, you know, what can we anticipate in terms of I guess speed and we're going to wake up one morning and they say, hey, they stopped the trial because it worked.
Yeah.
Versus in the traditional way you have to wait on. Please.
So it will look very different. The first difference is as soon as the gene therapy is allowed in humans, it will go straight into patients. It won't be tested on healthy volunteers. A lot of small molecules will be tested on healthy volunteers first. But you're not going to test a gene therapy on somebody who doesn't have Friedreich's. You'll go straight into Friedreich's population. So that's the first thing that will be different. It will start off very slowly. They will start off at a dose that they think has a chance of being effective because of the fact you can only do this once. With a small molecule, you'll often start off at a very low dose, which nobody expects to be effective, and slowly ramp up the dosing. With a gene therapy, it's not ethical to start with a dose that you don't expect to be effective, because that person can't go back and get a higher dose later. They will start with a dose that they think is likely to have an effect, but they will move very slowly. The first patient will be injected. They'll wait quite a long time to see if there are any negative effects before dosing the second patient. They probably won't wait quite as long after the second.
What's quite a long time?
I don't want to hesitate.
Hours, days, weeks, months?
Weeks to months. It will be slow, significantly slow. And that's purely about safety, because you don't want to expose too many people before you know it. It will accelerate. There's a company of Vexus that is looking at spinal muscular atrophy gene therapy. They started very slowly. They dosed very few patients initially. They've watched them for a long time. I will say that the results of that trial look spectacular on the first few patients, but only now, and we're really talking a couple of years later, they're beginning to ramp up to a bigger trial of more patients, because they wanted to watch those initial ones for a long enough time to make sure it was safe, make sure it was doing what it was supposed to do. And in that case, it looked fabulous. And if we could be half as successful, I would be extremely happy. But it will be very slow. It's not something that's going to happen overnight because of those safety concerns early on.
Jane, I think one of the other reasons why they're going to take a little bit more time, not only the safety issue that we have to follow, but this was something that Dr. Jacoby mentioned. We don't have a way to know when we deliver gene therapy yet how much will get to the brain. Same thing with the HDAC inhibitor. You take a pill, how much got to the brain, how much frataxin got turned on. We don't have a window to look in and to see that within hours or days. And because we don't have that kind of tool, we have to watch people over time to see if we can see changes. And a lot of the work that we've been doing with trying to develop biomarkers, putting people in MRI machines, drawing blood samples, we're trying to develop these tools that might tell us, be able to answer those questions, tell us in weeks and months, did we get enough frataxin increase in the brain? Did we get enough frataxin increase in the heart? Is it having a biological effect? If we had those tools to tell us that in hours, weeks, days, this could move a little bit faster. And so that is one of the real challenges. We can't go in and biopsy brains after we administer gene therapy to know how much got there. And so that is part of that time where we have to use time to know what's happening. And that is a challenge.
Following that. So what I'm hearing is, even though it's a one-time use because of the slower pace, it may be that the progression through the trials may be more on par with our traditional mindset on trials. We don't know, but
I think
it's not going to be fast.
No, I think in the long term it'll take at least as long as typically getting through clinical trials before it's approved. It's going to take years, because as Jim says, to see a significant change and a significant benefit, it's going to take time. Much as we're working on that and trying to figure out how to do that more quickly.
Jane, do you see the dosing to be different for children? And is there any, as children grow, does the effect of the gene therapy change?
That's going to be that's an important question in gene therapy. Yes, because the gene therapy affects cells, as the cells divide, it's only one cell, not these sister cells, so it will get diluted over time. Where we have an advantage in Friedrich's is that nerve cells don't turn over particularly quickly, heart cells don't turn over particularly quickly. So I would expect it to be reasonably persistent in this disease and the tissues we most care about. And things like muscular dystrophies, where your muscle tissue is turning over all the time, that's a real significant concern. And in terms of different dosing from children to adults, I think it's typically they dose by weight, but I don't know exactly what they'll do when they get to Friedrich's trials. That's still discussed.
Any other questions?
Could plasmids be used for gene delivery?
So what they use for gene
Plasmids?
Plasmids. So plasmid delivery has been tested in animal models. Pfizer did some work putting essentially naked DNA in. Distribution's not great. The results were interesting, but they decided it wasn't good enough to move things forward. So it's a possibility, but right now, uncoated plasmids probably won't work. But they are looking at other delivery mechanisms, endosomes, like nanocapsules. There's a lot of work on other forms of delivery. We looked at some of those a couple of years ago, and none of them are ready for prime time, but we're still looking.
I was wondering if you guys have any trials or research on, how do I say this, on taking, so obviously this is from a mom and a dad having the gene and then the kid has this. Is there anything that takes the gene out of the parent to stop from the source? Or say if two people already have a child with this and they want to have another child but they're scared of the outcome, is there anything that you can do science-wise where they can maybe fix it or block it out, or anything at all for caregiver or the cares?
So right now, ethically, you're not allowed to genetically manipulate embryos and grow them into people. That's one of those big ethical hurdles related to eugenics that they don't allow. And certainly you can have genetic screening and choose your embryo and choose healthy embryos. That's a possibility. Right now, gene editing or gene therapy at the embryonic stage is not done. Scientifically, is it possible? Maybe, but ethically, there are a lot of questions there.
Okay, if we're done, I think we're ready for lunch.